My name is Hamna Sarwar. I am from group number 1 GMM. All cells require a balanced quantity of purines for growth, proliferation, and survival. Under physiological conditions, the enzymes involved in the purine metabolism maintain in the cell a balanced ratio between their synthesis and degradation. In human, the final compound of protein catabolism is uric acid. All other mammals possess the enzyme uric acid that converts uric acid to allantoin that is easily eliminated through the urine. Overproduction of uric acid generated from the metabolism of purines has been proven to play emerging roles in human diseases. In fact, the increase of serum uric acid is inversely associated with the disease severity and especially with the cardiovascular diseases states. The enzyme pathways involved in the degradation of purines getting into the structures and biochemistry until the uric acid formations. The purine catabolisms. Almost all uric acid is filtered from the glomeruli, while post-glomerular reabsorption and secretion regulate the amount of uric acid excretion. The proximal tubule is the site of the uric acid reabsorption and secretion, and approximately 90% is reabsorbed into blood. Gout is a rheumatic disease that results from an excess body of burden of uric acids of a hyperuricemia, which commonly manifests as recurrent episodes of acute joint pain and inflammation secondary to the deposition of monosodium urate crystals atrophy in the synovial fluid or lining. Hyperuricemia is caused by increased production or decreased excretion of uric acid or both. Symptoms and the signs of gout. Any joint can be affected by gout, but it usually affects joints towards the end of the limb, such as toes, ankles, knees, and fingers. Signs and symptoms of gouts include severe pain in one or more joints, then the joint feeling hot or very tender, swelling in and around the affected joints, red, shiny skin over the affected joints. Symptoms develop rapidly over a few hours and typically last 3 to 10 days. After this time, the pain should pass and the joint should return to normal. Almost everyone with gout will experience further attacks at some point, usually within a year. Furthermore, renal involvement of gout due to monosodium urate disposition in the urinary tract can result in urolithiasis and urinary obstruction. Hyperuricemia is caused by increased production or decreased excretion of uric acids or both under excretion. The most common cause is thought to account for 80% 90% of the hyperuricemia. Although the risk of developing gout increases with the chronicity and increased concentrations of uric acid in blood, not all patients with hyperuricemia will develop gout. Diagnosis. For a definite diagnosis of gout, the urate crystals must be demonstrated in synovial fluid or in the tuphus. Synovial fluid should be analyzed by the polarized light microscopy. Once the definitive diagnosis has been made, repeat attacks do not require diagnostic aspiration unless there is a suspicion of the joint sepsis. A normal or low serum urate does not exclude a diagnosis of acute gout because the concentration may not be elevated during an acute attack. Class of anti-gout drugs. Xanthine oxidase inhibitors, allopurinol, febuxostate, uricostic agents. The primary uricostic drugs include probenicid, benzobromarone, and sulfiniperazone. Secondary uricostic drugs with other primary uses that have known uricostic properties include losartan and atorvastatin and fenofibrate.